Hello, everyone. Welcome to today's lecture called Unlikely Allies, Concepts and Considerations of Music-Based Therapies and Interventions in Tertiary NICU Care. Thank you all for joining us today for this webinar with Dr. Artur Jaschke, hosted by the Cambridge Institute for Music Therapy Research. I'm going to go over the Zoom webinar features quickly, just so you get familiar with them. Firstly, only the speakers can share their audio and video. Now, attendees, please use the chat to introduce yourselves. Where are you from? What do you do? Secondly, you can use the Q&A functions to ask any questions and upvote any questions you find interesting. We will dedicate 15 minutes at the end of Artur's talk to ask these questions. After the webinar, you will be invited to follow our newsletter survey. So please do fill it in so you are up to date for our upcoming events. Now, I would like to hand over to Dr. Jonathan Poole, Senior Research Fellow at the Cambridge Institute for Music Therapy Research. All yours.
Thank you, Leonardo. Welcome to you all. We've been looking forward to this wonderful webinar, which Dr. Artur Jaschke is going to deliver. I'm going to just introduce Artur just now with a short, abridged version of his biography. He's a very busy man with doing a lot of wonderful work. So Artur is a reader in music-based therapies and interventions and in ecologies of clinical neuromusicology at the Department of Music Therapy at Artes University in the Arts in Enschede in the Netherlands. I hope I pronounced that sufficiently. He specialises in the interrelation of music, technology, and brain maturation in clinical and non-clinical populations, and he is also a clinical research fellow in cognitive neuroscience of music at the neonatal intensive care unit at the University Medical Center Groningen, and also works with us at Cambridge Institute for Music Therapy Research in his role as a research associate at the University of Cambridge. And I'm lucky enough to collaborate with Artur on a very special project regarding autistic children, 7 to 11-year-olds, using music therapy for that. So with great pleasure, I would like to hand over to Dr. Jaschke.
Thank you so very much, John, for that wonderful introduction. And it's so great to see so many of you. Just going to quickly share my slides. So you should be able to see the first slide, which is Beyonce MD, music-based therapies and interventions. What I will do today is give you a bit of an overview of what happens in the brain when we listen to music, and slowly but surely transition towards the idea of what it means to have music therapy in the tertiary NICU and in NICU care, and in the end, a glimpse into the future. And the glimpse into the future will go from technology to current work that we are setting up with John as well, in CIMTR, which will be a nice pilot study. But to start off, music and the brain. And of course, I am preaching to the converted here, because you are all already know how important music really is, not just for our brain, but for human beings in general. And the beauty of the brain is we know so little about it. And what would we pay if we could just for a second enhance our brain capacity, just for a minute, know how we can use our brain even better? And these are all different approaches, not maybe for us, but maybe for policymakers to understand how important the brain really, really is, and that we can do so much when it comes to music listening, music playing, and music therapy, regardless of the population. So when it comes to music and music therapy overall and the interaction of music, there are 4 different stages of how we can contribute or no, interact with music, not contribute to, but interactive music. So the first one is passive listening. And passive listening is you sit in a restaurant, for example, there's music playing in the background, and you have a wonderful conversation with your table partner, and you kind of hear music and it's there, but you're not really noticing it so much because it's not really there into your attention. That's passive listening. So it's something in the background until the piece of music that you're hearing changes into something that you recognize. And it could be a song that you have listened to during the past holidays, or maybe something that triggers an emotion or a memory. Out of the sudden, the brain kind of loads more brain activity into the fore, and you are listening actively to that particular music. You even change the conversation and saying, oh, you remember when we were God knows where, maybe skiing, or we were down in Curacao and we were lying on the beach and we listened to the song, and you will be talking and actively interacting with this piece of music. Then you kind of decide that the food was all right, but let's go home, do something proper, and let's play that particular piece of music and rehearse it together and really engage with it, so you creating more activity in your brain while you're doing that. And after a short while, you get bored with kind of playing the same thing over and over again. You start improvising around it. And that's the moment when your brain really goes into overload and finds all the different connections and connectivities in there in order to reproduce and produce this particular piece of music. So an important part also for music therapy, you can of course do reciprocal music therapy. So you listen to it, you can actively and passively listen, also play with clients as well as improvise with them in order to get and find the best approach that is suitable for the population you are either researching or clinically treating. But before we can actually go into how we use music therapeutically, let's talk about the origin of music. Where is music coming from? What is music actually? You see the flute or bone flute here, which was found in Tübingen in Germany, and it's one of the oldest instruments found. It's estimated to be around 40,000 years old, which is a bone flute made from a bird bone. But we can imagine that drums or drumming will be even older than a bone flute, as being one of the very first instruments. So coming back to the question, where is music coming from? What is music? And in order to understand this, we shall listen to the sound of a star. Each star and each galaxy have their particular sound. The physicists will, of course, say, how can you hear music? It's a vacuum in space. You can't hear anything, any music at all, any sound at all, if there's no air pushing it and forth. And you're completely right. But what music really is, it's a combination of frequencies, a combination of particles that do reach our ear and literally touch us. So if we take this back and we look into the origins of music and we really look at when it happened, it must have happened in those inflations and quantum fluctuations of the Big Bang. And whether the Big Bang has happened or not, let's leave it at that. It's a Grundsatzdiskussion, and we will never finish that discussion. We could talk forever about this. But if we just assume that the theory of the Big Bang has actually its origin in those inflations and quantum fluctuations, we can state that music is as old as 13.7 billion years. And maybe that's the moment when I should stop and just say, well, that's the reason, and the reason alone why music has such a profound impact on our well-being and on us as humans, because it's as old as the universe itself. But it will be, or would be, a very short lecture, of course, if or interaction with you, if we just stop here and say, well, music is as old as 13.7 billion years. It is much more than that. So the origin is indeed in those different particles that create rhythm, they create melody, they create harmony, harmonic structure, all those things that really touch us in the way that it's either emotion, memory, or cognition. So now that we know that music is 13.7 billion years old, and it literally touches our eardrum and makes it move and creates or recreates a mechanical signal and translates it into an electrical signal so the brain can interpret it, let's look at the different pitches and different frequencies from low to high that we can actually hear. And what you see here in front of you is your cochlea, so your inner ear, and the inner ear is divided in different frequencies and pitches, and each of those segments of the cochlea will react differently to different sound, like for example thunder, just more at the lower spectrum. A dog barking will be next. Human speech.
Ah.
A baby crying, telephone ringing, or a bird singing. So as you can see, there is a wide range of pitches that we can actually hear that have a representation in the cochlea. The cochlea translates all those informations into an electrical signal so we can actually research it and look at it in the brain. Thankfully, not anymore as depicted in this painting by Rembrandt here. We don't have to actually open the brain up anymore. We can look into the brain through wonderful and beautiful machines like the EEG, the FNIRS, which is functional near-infrared spectroscopy, the MRI, all those different beautiful tools that we have in the clinic as well as in research. So I'm going to show you a fMRI video of the brain in a second, but before I do that, knowing that it affects us so strongly, music is. The question is, are we our brains? Can we just simply argue that understanding the brain and understanding an electrical signal in the brain will answer all the questions that we have about what music is in the brain? Or is it something more? Are we maybe our heart, our soul, our body, and a form of embodied cognition maybe? And this, again, is yet another of those massive questions of nature, nurture, and beyond that we have no direct answers to, because Plato back in the day has argued the same thing, and he said, no, the brain has to be the seat of our mental processes. Aristotle, being an excellent student, he completely went the other way than Plato did and said, well, no, it's the heart as the organ of thinking, perception, and feeling. The brain can only cool the passion of the heart. And Hippocrates said that men ought to know that from the brain and from the brain only arise our pleasures, joys, laughters, and jests, as well as our sorrows, pains, griefs, and tears. And this continuous argument of brain versus heart, heart versus soul, soul versus body, known as dualism in philosophy, is one of those topics that we are still struggling today with when it comes to theoretical neuroscience. Are we our brains, or are we maybe a combination of body and mind? Is there something more than the mind? Is there more than the brain? If we think about consciousness and conscious experiences. So it's an ongoing discussion. However, it's very interesting discussion, and it's very useful once it comes to the application of music in therapeutic settings, because we are more than our brain. We are also a body and an embodied individual that is in this world to perceive the world as it is. But for now, let's just look at the third renaissance of the brain. And if you are planning to go to Italy, or just been to Italy, maybe to Rome for your holiday, and you are in the 16th chapel and you look up, you will see this wonderful painting. And if you have some Photoshop skills, you can very nicely Photoshop a brain into this painting, which was the original idea of the artist, to show that there's more than the divine idea of what science can be. So science can show us so much more. But as promised, the next slide will be a live MRI of a brain listening to tango music, and you will see blue is less activation or slight deactivation, and red is activation, so more oxygen going into that part of the brain. And you will see a wonderful interaction, an elegant dance between different brain areas when listening to tango music. And if you translate this interaction between activation and deactivation, you translate it into a two-dimensional plane, you see here the well, underground map of your brain pretty much, with the frontal lobe strongly represented here, with areas in the parietal lobe, the cerebellum, the hippocampus, the amygdala, brainstem, the temporal lobe, the thalamus in the center, and even the motor cortices, which are coordinating all sorts of movement, as well as this little triangular here with the anterior cingulate cortex and the nucleus accumbens, which are partially responsible for dopamine. And dopamine is one of those hormones that makes you, on the one hand, extremely happy and euphorious, but on the other hand, as well, creates a certain connectivity. And what you see here is the dopamine release and the dopamine interaction between individual neurons while listening to music in real time. So on the top left corner, you see the time running down in seconds, and you see how those dopamine interactions are created while listening to music. So it's not just our brain, it's not just our body, but it's even the smallest hormones and molecules that are interacting when it comes to listening to music. If we now translate this idea of music triggering the whole brain and we look at the development of the brain, and now we're slowly but surely transitioning towards the music therapy in the tertiary NICU, and we look at how the brain develops, we see at 29 days, the first kind of spinal cords are forming here, 33 days going on. At 59 days, we see the first head formations with a nose even kind of can be spotted here, and a mouth and an eye. And once we get into the realm of around 20 weeks, and especially at 16 weeks, we, as little feti in the belly of our mother, start to perceive the first sound. We don't know what it is, but we start perceiving sound at 16 weeks. And if we move towards the tertiary NICU and we have 20 weeks here and the cutoff point maybe here at 22 roughly weeks, that was one of the youngest children that we had in the NICU during one of our researches. So if you see 16 weeks to 22 weeks, it's an extremely small gap there. And if you look at 6 months even, the brain is not fully developed yet, but at 22 weeks we managed to keep the child alive, and it survived in the NICU even afterwards for a longer prolonged period, and it's perfectly fine now. There's not much wrong with the child. So you see, it is extremely crucial and important to understand those stages in brain development and what and when to do what, and the timing and the window and the framing of it have exactly right, and especially when it comes to neonatal intensive care. So coming into neonatal intensive care, and just remember, just going to quickly go back, remember between 16 and 22 weeks, where the brain is really not fully developed yet, and it's only fully ready to be born at around 9 months, and it will continue into development until old age, of course. But let's look and let's focus just on the neonatal brain and see how underdeveloped it is and what we can do with music therapy in the NICU there. So music therapy in the tertiary NICU means much more than music. It's not just putting on a CD or a MP3 player and just play any odd song that you think may help. It would easily overstimulate the child. It would easily destroy all those very fine fibers in the brain that have been created so far, because it's too much. If you remember, it's harmony, it's rhythm, it's melody, it's pitches. All those things together are so complex. And if you remember the whole map of your brain, all those brain areas are activated in adults and young children when we listen to it. So if we would activate this in a child whose brain is not quite developed yet, it would overstimulate the child very, very quickly. So what we do in the NICU is we use individual notes, sometimes even individual sounds that mimic different sounds around the ward. And what we've done, we had 70 infants with a 90% participation rate. We were extremely lucky and happy with that. With a gestational age of a median of 27 weeks. So the youngest was 26, the oldest 28. We used different materials. So we looked at a maternal and child inter-questionnaire just to find out whether the parents were musical or were not musical, what other strengths and difficulties there were with the child and the parents. We looked at the NEO comfort score, which means how comfortable is the child while in the incubator. We looked at near-infrared spectroscopy. We analyzed general movement, or general movements for monitoring, which means the more fluid a child's movements are, the better the cognitive development is. And we looked at DNA methylation to see whether we can actually switch on or switch off gene markers that are associated with stress. And the music therapeutic intervention was the Song of Kin. Some of you may know it, by Joanne Lowy from the United States. 10 to 15 minutes, parents were present, the incubator doors were closed, and we tried to keep the noise between 45 and 60 decibel, which is 45 is quiet. We're trying to push it down to even 35. A regular NICU hangs somewhere in between 55 and 60 decibel on a calm day, which is rather loud and noisy if you think that the Concorde starting is around 100 decibel. So there's only 40 decibel in between there. And we used fully trained NICU music therapists who were trained to perform that intervention and had a lot of clinical hours in the NICU as well as to know what to do and how to do it. So we looked, of course, first at the feasibility of comfort and overstimulation. And as I said, we looked at the value of the NEO comfort score. And the NEO comfort score shows in this depiction here in this graph is that before the music therapeutic intervention, there was a rather normal kind of non-distress aspect of the child. During the music therapy, it kind of shrank a bit, but of course we had quite a few or large SD value, as it's so beautifully called in science. So the spread was rather wide, but afterwards we could actually see that it remains the same for the child. So the child did not feel increasingly uncomfortable while listening to the music. And that's one of the first things that we tried to debunk, because the first that you usually hear when it comes to music therapy in the NICU is that it will always overstimulate the child. What this has shown us was that if you use 1 or 2 tones carefully in a NICU in order to mask maybe the alarms of the heart monitor, you can create a soundscape, an environment that will not overstimulate the child. So the child will be as comfortable as it can be. The next step was looking at the noise levels during the music therapy session. And what you see here on the left is 1 will be extremely noisy or noisy and 5 would be quiet. So before we started the music therapeutic intervention, it was rather noisy on the wards, as you can imagine, nurses walking in and out, doctors coming in, parents talking, all those kind of things. Once we started the music therapy, the whole ward quieted down. It all calmed down. Even the nurses started to whisper. Parents said, "Why on this music? We should whisper as well." People started walking slower. Everything calmed down, and this effect was prolonged even after the music therapy has stopped for up to 45 minutes on the ward. So what we see is not just a direct impact music therapy can have, or specialized music therapy in the NICU can have on the child, but it has a direct impact on the whole ward and even on the calmness of the nurses. Looking at the impact that it has on the child, looked at oxygen supply, and we looked at oxygen consumption. And why are we looking at these? Because we used FNIRS, as I said before, the functional near-infrared spectroscopy, which measures oxygen levels in the brain or in the brain tissue. And what we found is that while the music therapy was performed, the flow of blood has increased throughout the body, meaning there's more oxygen going throughout the body as well as to the brain. There was impact on blood pressure and resistance, and even cardiac output. And the point about cardiac output is you can synchronize with the child while knowing the heart rate and the blood pressure. So imagine the child has a heart rate of 180. So it's and then you start playing those 2 notes, pum 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 pum, in that sort of speed. So once you create that synchronization, you start to play slower. The heart rate will lower together with the lowering or the slowing down of the 2 notes. So it's so you can actually, don't want to say steer the heart rate, but you influence the heart rate directly through synchronizing with the heart and the 2 notes that you're just playing, and therefore creating a lower cardiac output, which is obviously in that, I will show you another FNIRS picture in a second, which will make it more clear, but it will show the oxygen content will be increasing, but the blood pressure and the heart rate going down, therefore helping to increase consumption of oxygen and contribute to sedation, which means while lowering the heart ever so slightly, you will create an impact of the child slowly but surely falling asleep and calming down. And we measured this with FNIRS, as I said. You see it here very nicely, the oxygen supply before the music therapy in blue. Then during music therapy, it increased here and stayed increased. And why is that, you would ask? Because this participant, participant A, was rather sedated already. So the child was extremely calm, and we wanted to animate it, to enhance its cognitive output. And in order to do so, we used music therapy that enhanced the heart rate and the blood pressure. And as you see here, during the music therapy, it went up as well, and it was prolonged afterwards. In participant B, extremely active, and we wanted to calm the child down and actually make the child fall asleep. We used another method when it came to synchronizing with the speed of the heart rate and lowering it down just by playing ever so slower and ever slightly so slower. And you see that the oxygenation levels went down, increasing the consumption therefore, and this effect was prolonged for longer. In participant C, we see a rather random FNIRS pattern here, which goes up and down, so it's very nondescript. So the body does a lot of things at the same time because it just cannot make the connectivity right. And during the music therapy session, we actually managed to get the oxygen in a more straight line, which means that the different areas that were activated during the listening of the music, or the 2 sounds or 3 sounds that were used, or maybe the humming or the singing of the parents while it was used, create a more steady impact of the music, therefore creating not just the consumption, but also the supply, managing to balance those two and create a much more positive effect to the child where it calms down for the duration of the music therapy. The moment that we stopped, it started to go everywhere again. And the differences in these 3 patterns are really akin to the differences in the NICU and the population that you will encounter in the NICU, because not every child is the same. There are different pathologies. There can be neurological problems, there can be gastrointestinal problems, there can be pulmonary problems, cardiac problems, cardiological problems. So all these different problems will cause different patterns in the FNIRS, and we can actually go in with the music therapy and work on each individual child and each individual pattern, as well as each individual pathology. We further looked at the role of music therapy with infants with perinatal brain injury, and perinatal brain injury is an injury that's created way before birth. A child isn't born preterm or extremely preterm, and what we see is that the child has severe problems in the way that the brain is communicating and the brain is functioning. And what we usually do when it comes to perinatal injury, well, we've done a systematic review to see whether there are any studies that have working on this. And yes, there have been quite a few, 11 in total. And I'm not going to bore you with the whole thing, but what we look is the outcomes within these different systematic reviews. And one of those are the MRI results, the change in oxygen saturation, change in heart rate, weight gain, and neurodevelopment. And what is important to know when it comes to perinatal brain injury, and especially to hyperischemic encephalopathy, it's HIE, is that after birth, so immediately after birth, you take child, because you can diagnose perinatal brain injury early, so before birth. We cool the child down. So from a average 36, 37 degrees Celsius, we actually cool the child down to sometimes even 27, 28 degrees body temperature. And over the period of 3 days, we slowly but surely warm the child up again. And this helps to reset the brain. And that reset is believed, and is actually scientifically proven as well, partially, that the reset of the brain allows the brain to find new connections and work in a more normal way, in inverted commas, as you would expect from a child that is born without a perinatal brain injury. And looking at those different different studies that we found and the role of music therapy in perinatal injury, we've seen that the results from this review showed auditory stimulation, both pre-recorded and live, and it had a positive effect on infants' feeding ability, pain scores during procedures, and neurological outcomes. Another important finding was that most studies used auditory stimulation performed by healthcare professionals rather than a specially trained music therapist, which means, there's still a wide gap between how music therapy is actually administered in neonatal intensive care units, and that's across the world. It's not just in the UK, but also in mainland Europe, on the continent, in America, in the individual hubs where they use music therapy in the NICU, but not an overall standardized protocol quite yet. Specialized live music therapy was administered by fully trained therapists, thankfully, and it increased the effect of well-being, pain perception, and feeding in children, much more than the music that was performed by healthcare professionals. When engaged in musical exchange with shared rhythm and affect, the infant's coagulation and stabilization was supported, as shown by the studies that we found. An investigation is required into the appropriateness of providing music therapeutic interventions during the cooling period, especially. You can't use music therapy when you are when the child is born before cooling, because the time window is way too short. But while the cooling period is in place and the warming up period, you can actually use music therapy much stronger, and you can experience an acceptability of parents on this as well. And last but not least, future studies have to really focus on should consider gradual increases of stimulations when it comes to auditory, visual, and tactile. Sometimes we try to rush way too fast into something rather than slowly building things up, and it's extremely important in those children. I also mentioned that we looked into DNA methylation. And what is DNA methylation? It is measuring the locus-specific pyrosequencing individual candidate genes, and this means you take all those candidate genes that you see in table 1 here. These are all genes associated with stress, and those stress genes, you collect a stool sample at the start of the intervention, 3 weeks after the intervention, and 6 weeks after the intervention. And by methylating it, so by going through certain chemical processes, you can actually look whether those genes, so these white nodules here and the red nodules there, can be switched on or off. And what we found is that during or after the music therapy, I mean, so at 3 weeks after and 6 weeks after, those stress nodules or stress candidate genes were switched off in those children when they were receiving music therapy. Same at the start of the intervention, they were rather high. They were extremely stressed when it came to the DNA. But while we collected those samples during the music therapeutic sessions, we could actually see that we could switch on those target genes and epigenetic regulators when it comes to stress, which means that by providing just a couple of nodes that mask the very noisy environment a child is in the incubator already helps to reduce stress significantly. With these words, I would like to take you into the future. And with the future, I would like to ask you to close your eyes for a second. Just imagine that you are back this morning when you were still lying in bed, a very warm blanket around you, and nothing in the world to bother you, all nice and calm, wonderful and beautiful dreams of beaches and wonderful places. And then you are woken up to this. What you're hearing is the noise inside of an incubator. So that noise, a constant heart monitor alarm, other babies crying, people talking, this constant shh sound, which is the air being pumped into the incubator, as well as the warming and heating element to keep the baby warm. All these sounds are inside of the incubator, audible to the child. If you remember how malleable the brain is at this early stage of life, those sounds are imprinted onto the baby's brain and onto the perception of the different sounds. So sometimes what we hear from parents that left the NICU together with the child is that the child cannot fall asleep unless you put on the Hoover or the hairdryer, kind of mimicking the sound. Often you see parents walking down the street with the iPhone next to the child playing white noise, or maybe even kind of a continuous sound, which helps the child sleep. 90 to 95% of the times when somebody walks with that sound with a baby, that child has been born preterm and has spent a time with the incubator because it has gotten adjusted to that particular sound. Obviously, this is not desirable for the development of a child. And what we are currently doing, and that's one of those future aspects that we're looking at, we are trying to build an active noise cancelling incubator that will diminish the sound of the ch and the heating element, as well as the beeps and bleeps that come from the outside into the incubator. It's not much of a challenge to create an incubator or a pod that is completely silent. It's more a challenge to actually find the correct and the right sounds that will help development of the baby's brain. Because when you're in an incubator, you need things like voices, like a speech, like different forms of tones to help the brain make all those different individual connections. You know, think of the huge map that we had before. If you don't train those individual connections, the baby will not understand what those sounds will be. And once it leaves the NICU, it will be overstimulated by all the different sounds. But this incubator form is really working with different AI or artificial intelligence and machine learning algorithms to filter out the bad noise and allow the good noise, like, for example, speech or music or birds singing or whatever positive sounds we can imagine that would enhance a baby's brain and development. While we're looking at the sound in the incubator, we are also installing motion capturing cameras. And I talked already about general movements. I briefly mentioned it, about the more fluent movement of a child as compared to a more staccato movement. And what you can see in those videos is that the child is recorded during its time in the incubator. And what the AI does is it's not taking over the diagnostic process from the experts, but it helps in minimizing the diagnostic procedure, because to analyze a whole 4.5-hour video of general movements, like pretty much all video observations that we have in music therapy, take a lot of time. And in order to cluster different movements and different patterns of development, we can already ask the AI to digitalize those movements, create representations of the child and how the child develops, and then a trained professional who knows how to score these can look at the moments of interest during that period that the child has been in the incubator, minimizing the time of diagnosis and also enhancing the period that we can actually intervene and create new interventions, whether it's musical or any other non-pharmacological intervention to support cognitive development. Bringing this into yet another future is looking at how we can deal with hypersensitivity and hyperacusis when it comes to autism spectrum conditions. 33 to 35% of all children who are born into an incubator develop a form of autism. So what we will do in the future, we are not there yet, we will use the development that we are currently doing of the incubator, the active noise cancelling incubator, record those different general movements, the fidgety movements, as well as the Bayer scales of infant and toddler development over a certain period of time, up to 12 months, with another 3 months, give or take, and then see whether we can look at the brain structures in autism spectrum disorders. Here I have to say it's not the autism spectrum disorders that are developed over time, but more the genetical variant, as we can actually look into which child has developed or will develop a form of autism at a very early age, at around 2 months already after birth. We can see whether there is a genetical variant into it. As I said, that's kind of the sounds of the future. We're not there yet, so we're going to look into this in the coming years. Honorable mention to Nina Wollersberger, Rebecca Atkinson, Natasha Larkin, Jonathan Poole, and myself. I don't have to mention really, but we just started the NHS NICU music therapy pilots together with CIMTR. So what we will do, we will go into the NICU together with the music therapists from Chiltern Services in London. And what we're going to do is looking at the 12 music therapy sessions offered twice weekly by a music therapist, all clinically eligible children will be before 36 weeks, as well as preterm and extremely preterm children, looking at the outcomes that I have described so far. So hemodynamics, so everything that has to do with blood, oxygenation, comfort, feeding, parent-child bonding, and following up towards development of child development, the cognition and how it develops, emotion, behavior, and of course, as well, parent well-being and child bonding. And I have to say, even though there has been a lot of research on the continent, there's been a lot of research in the US, there has been no research or hardly any research at all within the NHS setting. And together with CIMTR, we will be the first to really pilot this music therapeutic approach in the NICU this year and in the years to come as well. So to round up, it is all about the patient or the human when it comes to music therapeutic interventions. We talked about music and how it affects us passively, actively, playing and improvisation with different brain areas loading. We looked at the scientific side, whether we do a qualitative or quantitative analysis, whether it's a review or whether it's a clinical trial, and how those interact and interplay when it comes to understanding music, and not just music, but individual sounds. We talked about technology, how we can use technology rather than be abused by it when it comes to innovation, development, creation, and modeling to have the best outcome for the child. And last but not least, the medical side with care, cue, and dare, sometimes daring to do something else, just playing two individual notes rather than a whole symphony to create a better development in a child. Only then we will understand how to move away from transdisciplinary through interdisciplinary, through multidisciplinary research towards a de-disciplined approach where we find the boundaries of our own research and our own capabilities in order to find the next steps that we need to take when it comes to NICU music therapy. But in the end of the day, maybe not everything that counts can be counted. Maybe we will not be able to find the reason why music has such a profound way and why it affects us so strongly, even though it's 13.7 billion years old. But in the end of the day, it is up to you. Are you joining us by taking the red pill in this wonderful journey into music therapy and the neonatal intensive care unit? Or will you take the blue pill and say, maybe it's daring too much and we should try other things? I strongly urge you, take the red pill. It's a wonderful journey, and we have seen some wonderful things happening with children while they are in the incubators, as well as to the parents and the nurses, and something that we will continue into the future. So with these words, thank you so very much for your attention. Honorable mentions to the team that have helped shaping this research so far, as well as the research nurses in Groningen at UCL as well, University College London Hospital, and the team at Artur at CIMTR. Thank you so very much for your attention. I hope there are some wonderful questions to come.
Thank you very much, Artur. That was wonderful. It was a wonderful presentation. Lots and lots of wonderful information in there. We have a few questions, and I'm sure a few more now that people can gather their thoughts and process what you've been talking about. We'll put some more questions in as well. So the first question is from Annika, I think. Do you also include the music therapy in the maternity ward when a preterm birth may be expected, or do you start at the NICU? And that means in the study.
Yeah, I mean, we have in the study that I presented here, we have started in the NICU, so one after the child was born. But in the studies that we are doing now, we starting already as soon as we know that a child is, or a mother is at risk of giving birth preterm. So we now kind of shifted, because the first was a pilot. We wanted to know whether it has any effect at all. And from here, we're now looking into the ward as well, when a mother is at risk of giving birth preterm or extremely preterm.
All right, thank you. There's a question from Katie Richards. Are there any plans to get music therapy into NHS NICUs as standard in the future?
That's the dream. That's the hope. I mean, the problem, of course, is, you know, as everything needs to be evidence-based nowadays, and especially when it comes to clinical trials, we need to find all those different approaches that work. And unfortunately, the NHS, as amazing as it can be, does not accept the findings that we have found in Europe and in the US. So they said, you know, but yes, of course, it works on the continent, but does it work in an NHS setting? So that's the reason why we, together with CIMTR, we're going to do the pilot research and actually continue it further into more hospital settings as well. So the future should be NICU in the NHS, so we hope.
Okay, and that partially answers the question. I think there's a bit of an offer coming on this one. This is from Karen Morrison. Would you like to expand the pilot project into other NICUs in the UK? Karen works in the NICU at Bristol Children's Hospital.
More than happy. Just send me an email and we can get in touch and actually get arrange everything. And we would love to expand it into Bristol Children's Hospital. Thank you so very much for the offer.
Oh, wonderful, thank you. So, and a question from Esther Mitchell. Is CIMTR looking to involve other music therapists currently working within the NHS NICU?
I mean, that's a question for you, John, really. Yeah.
As it is.
Well,
at the moment, we're focusing on one site at the moment, aren't we? Because of because it's a small pilot and the funding available. But I think we will look to expand and to do something more multi-site, I think, depending on what we kind of come up with in this first pilot. And of course, anybody who is interested in supporting that kind of study because of where you might be working, please do contact us and we will keep your details ready and available for when we put in some more applications for funding and try to expand further out and to develop the evidence. Okay, yes, and Katie says that she would be very happy to join the pilot too. All right, so are there any more questions?
I mean, the thing is, as we are in the pilot, just to elaborate on this, we are in the pilot phase with the NHS right now. We want to see how far we can actually go this year and next year. We're currently also developing a larger protocol for a 8-year study, which will be submitted next year to move from the research that we've done in the continent and in the US, kind of trying to replicate it partially, involve the technological side of the incubate, and then push it forward. So, I mean, there will be much more coming in the years ahead.
Okay. There's a question from Nicola Leonard. I know there is an appetite for additional training and services in the UK. Are there any plans to bring training in the UK?
There are plans. We had those plans for the past 2 years. Currently, we are offering the NICU training Tier 1 and Tier 2 in the Netherlands and Enschede every year. So you're more than welcome to join those trainings. I could share a link maybe later on, when the next question comes up. I'm going to look it up, and you're more than welcome to join us at the training. It's going to be in November again this year. So we will be planning and getting it to the Netherlands, to the UK as well, and see how we can combine those two in terms of strengths, because we have heard a lot of interest for training and a lot of really eager, especially music therapists, who would love to learn more about it. So we will try as much as we possibly can. And then Anneke is saying great training. She can really recommend it. She has followed it herself, and she's one of the NICU music therapists that work in the Netherlands together with us in our research and individually as a NICU music therapist.
All right, thank you for that. Jörg Fachimer, one of our professors, has a question for you, a bit more technical now. Great lecture, Artur. Can you tell us more about the entrainment of the heartbeat of the infant and the 2 tones added to slow the pace down? Have you analysed this?
Yes, thank you very much, Jörg. I kind of expected that question from you. I mean, what happens with the heartbeat? Once you see, because the beauty of a NICU, and like every ICU or intensive care unit, is that the patients are attached to a heart monitor and attached to a direct view of how the heart actually performs. So what you can do is you take the different highs and lows of the heart, and you take each individual point, and in between those rhythmic changes, you can actually incorporate the individual musical notes, determining the speed of how you can entrain the music into the heartbeat. So once you have the exact speed of the heartbeat, and take the highs and lows of the electrocardiogram, you can incorporate the musical speed and the musical rhythm on top of that, and then see how it changes. So it's not just the nearest, but the nearest is directly linked to the ECG in the NICU, and therefore creating this pattern and how we should play the music and what.
And just to add on that, how do you incorporate the melody? Is it an algorithm that you've based, or is it a music therapist that's playing?
Oh, in the incubator, you mean? I mean, in
Yes.
the incubator, it's always a music therapist that performs the music. So what we do in the active noise cancelling incubator is we measure the heart rate and the brain waves. And when we see that the child is distressed, we play the voice of the mother back, either singing or saying some soothing words. We do not play any music or any sounds through an AI, because what we don't want is that it's going to be so digitalized that you can just create any odd pod. The thing is, it's so individual when it comes to those individual tones that you need a human music therapist next to the NICU to actually do that. So if you want music therapy, you need a human. When the child is distressed and a music therapist is not there, you can actually play the mother's voice or the father's voice to soothe the child. And based on the heart rate variability and the brain variability and the general movements, how fluent they are or non-fluent they are.
Fantastic. And so is the heartbeat from the ECG sonified so that the therapist can...
Well, it is not sonified for the child. We try to not do that because it creates yet another layer. But for the music therapist, it is. And it's also for the nurses. And there are differences per NICU. For example, the NICUs in the Netherlands have got rid of all the sounds that are happening outside of the pod. So all heart rates, alarms, pretty much everything that happens or used to happen at the bedside now happen at the central hub, and all nurses carry a wearable where the alarm is linked to their child that they are caring for, which means that you minimize all those kind of sounds. But in order to actually sonify the heartbeat, when you want to do it in the therapeutic session, we give the music therapist a wearable and headphones, and they can actually hear it and then interact with the child. So that's how we're trying to minimize the sound on one hand and create a auditory feedback loop for the music therapist on the other.
Yeah, I
Fantastic.
see. It's selecting the sounds that you want to hear, isn't it?
Indeed.
I'm just aware of the time and that we have a few more questions that I think. So there's one from the chat from Elizabeth Howe. Do you find that parents are receptive to NICU MT at the very vulnerable time of having a baby in the NICU?
Yeah, I mean, that's one of those things that we have been researching, and one of the papers is currently on the review. There is a unbelievable openness to music therapy when it comes to the NICU. Parents feel extremely vulnerable, and especially in countries like Germany and in the Netherlands, they do not want to share necessarily their own feelings about it. So we've noticed that they did not benefit from a group session for parents where they speak about the problems in the NICU, whether there's music therapy or not. But when you actually say that the benefits outweigh the dangers when it comes to music therapy in the NICU for the child, you see that parents are extremely open to go for it. They say, well, I've heard about it. Yes, of course, music is good because it's a general rumor that is going around that every music is fantastic for our development, which is true on the one hand, but it is much more nuanced than that, of course. And the same applies for the NICU. So you interact once you talk to the parents. We had not a single parent in all of the research that we've done that had refused music therapy for the child, because you sit down, you have the intake questionnaire, and you have the intake conversation with the parents, and you have the chance to explain it exactly in that vulnerable time, and they are open, they're welcoming it very open-handedly.
Thank you for answering that. I've got two more here, one from Katie Richards. I know you didn't mention this in your presentation, but do you know whether there have been any developments regarding PAL machines being created for use in the NHS yet?
And the PAL machines, you mean the pacifiers, I assume. There's just those digital pacifiers.
I think so. I think that's what it's, yeah.
I wouldn't know whether there are any currently created for the NHS, I have to say. I would have to look that up. I'm not aware of it because generally there's nothing related to even the pacifiers, that are used for musical purposes in the NICU. So there's nothing really in the NICU that sings or speaks music currently in the NHS. So I wouldn't know. I don't want to say that there's none, but I'm aware of.
Okay. And the question from Marcy Baliova. What is the optimal beat per minute to induce via music to make sure the calming effect is achieved? Are there any variations?
Optimal beat per minute is the heartbeat of the child. So if the child is at 190, you use 190 to go down or up, preferably not up when it's 190. If it's 160, you start at 160, and you can't use 160 BPM for a melody. It's going to be it's way too much. Just use half time, and then kind of see where you rhythmic. That's the reason why you need music therapists, because you don't just need the therapy and the nursing side, you also need the musical side. And a music therapist knows very well how to half beat or kind of quadruple down the beat, when it comes to a certain high beats per minute rate, in order to still keep it rhythmical and still keep it coherent.
Mm. Thank you so much. I have a question for you, if I may. We are going slightly over time, so I do apologise. But I was just thinking about relating your work to the work of, say, Janine Bauer, who looked at the kind of neurophysiological processing in the developing brain, and looking at musical processing, basically. And I was just thinking about these noises, and there are lots of high frequencies and things like that. And of course, this is not really where what would be experienced in utero. In utero would be much more muffled, and you get lots of lower frequencies, wouldn't you? And I was just thinking about whether there's any evidence to do with how you would moderate the frequencies played in terms of tones through in that kind of 16 to 22 week period that you identified as very key.
I mean, in the 16 to 22 period, we can't look a lot at the development of the brain. I mean, it's extremely difficult to MRI or functional MRI or DTI a child in utero. But what we see is, when the child is born at 22 weeks, we can analyze the connectivity that is present at that particular moment, and then see how that would potentially develop through different sets of algorithms that we can implement in a computer model. What happens with those frequencies and how to determine what to play to get the perfect, as you said, muffling sound, the perfect kind of range of frequencies, is we record the sounds in utero of the mother. So we actually hear what the child would hear when it's still in the belly of the mother. So we know what frequency ranges we can use and how the sounds are muffled, because every person is different. There's a different layer of skin, there's a different layer of muscle, maybe, or the organs are differently adjusted. There's always a different frequency layer there. And we can use that information to replicate those frequencies onto the sounds that we want to play back to the child, so it sounds as natural as possible as it would be in this critical period between 16 and 22 weeks.
Thank you so much. I think we might have to finish in here in just a sec, but there is one more question from an anonymous attendee. Sorry if I missed this information, but were the 2 musical notes used in your study taken specifically from the Song of Kin? If so, were they specific chords or intervals each time?
They can be taken from the Song of Kin. Preferably you take them from the Song of Kin, because you can build up from there. And those 2 notes, I mean, they have specific chords and intervals indeed each time to represent the heartbeat of the child. Pock, 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 pock. So it could be a third, it sometimes could be even a fourth, and it really depends on how the heartbeat sounds. Then yet again you have the knowledge of a music therapist with kind of bolding out, and italics, the music, by identifying those 2 notes and then trying to find those pitches that would even go together with the heart. But they are usually used from those chords, from a Song of Kin, in order to build on, so the parents can sing along with the child once you identify those sounds. On the other hand, we sometimes have to use the sounds from the heart monitors, because each manufacturer uses different pitches for the heart beeps, and sometimes you just start, rather than with the Song of Kin, you start with the 2 notes or 3 notes that are in the heart monitor and create a melody with those to mask the heart monitor, rather than introducing more noise into it. So if you have pop 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 as a heart monitor, you add 2 notes, pop 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 pom, pop 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 pom, and all of a sudden you have a melody. So it really depends on what and how you are working with the child, and what sort of pathology the child has, in order to balance the perfect healthcare application there and intervention.
Fascinating stuff. Dr. Artur Jaschke, thank you so much for this wonderful lecture, and thank you to everybody who has attended and listened and watched. and may ask questions. Thank you to all of you. I'm going to hand back to Leonardo now to close this webinar off. Thank you.
Again, thank you so much, Artur. That was fascinating. And I want to remind the public that you have a book that's out now, Mind the Music. I've ordered my copy at the Waterstone, so I'm looking forward to reading it. Now, please make sure to join our newsletter. I'll put the link again. You will be notified for our next lecture by Ri Asano on the 3rd of May, and you will find more details about it on our newsletter. Once again, thank you so much for coming round, and we'll see you on our next CIMTR lecture. All the best. Okay.